Hi friends, I'll be just giving a brief overview on this quite an important topic, but I'm sure most of my intensive grade friends would be following this. So this came as a nice review article in 2024 as to 8 rules for the hemodynamic management of TBI. So quite intuitive, so there's nothing extraordinary that I'm going to tell you, but they're just encapsulated and tried to emphasize on certain key components that we need to pay attention to. So what have we been doing until now with regards to TBI? So with regards to TBI, all the nurses who work in my ICU know something called 7 normos. In the chart, we write maintain 7 normos for all the patients who have anything to do with cerebrovascular incident. So what are the 7 normos? Normoxia, normocapnia, normovolemia, normotension. We don't want hypertension, which is very bad. Normothermia, normoglycemia, normosmosis. So this is something which we dim into each and every of our nurses, let alone all our trainees. So in the chart, we write for anyone with a head, with a cerebrovascular incident of any nature, we write maintain these 7 normals. So this is fairly intuitive. So this particular review article tends to elaborate on certain aspects of this. So there's nothing very new that I may be talking, but it is just encapsulated as the 8 tips. So it came as a article in the European Journal in 2023. Sorry, I said it's 2024. 8 rules for the hemodynamic management. So here they talk something about brain heart crosstalk. So this is something which may be of interest to our trainees. So whenever there is a cerebrovascular incident of any nature, it has an impact on the cardiovascular system. So this is what we call as brain heart crosstalk. So what happens? There are each areas, different areas of the brain which are associated with certain sort of deleterious effects on the cardiovascular system. So the prefrontal, if there is a prefrontal cortex that is affected, so there is autonomic control on the cardiovascular system that tends to get affected. Then when the insula, so when there is an injury of any nature in the insula, so it tends to cause more of atrial sort of a arrhythmia. So it can be atrial fibrillation, atrial flutter, or some sort of a blocks. So basically, it has some impact on the atrial contraction and atrial arrhythmias, and it also can cause Takotsubo cardiomyopathy. So it means it does produce sort of a stress on the myocardium. If hippocampus, due to traumatic brain injury, is affected, so it tends to cause myocardial dysfunction and systolic dysfunction, leading to heart failure symptoms, along with atrial arrhythmias or ventricular arrhythmias of some nature. But if it is brainstem, then predominantly you would tend to have, it can have hypertension sort of a response if hippocampus is affected. If brainstem is affected, predominantly it can cause tachybrady sort of a symptomology or a signs that can manifest. So they can have arrhythmias of any nature, which could be tachyarrhythmias or it can be bradyarrhythmias. So when we talk about brain heart crosstalk, which possibly can be asked in an exam for DRNBs, this is what it means. So whenever there is a cerebrovascular incident, it can have a deleterious effect on the cardiovascular system based, and the type of cardiovascular symptomology that manifests depends on the structural areas that get affected due to cerebrovascular incident. So this is what is all about brain heart crosstalk. So we need to have some understanding. So even neurologists, neurosurgeons should have this absolute clarity in mind. When there is a TBI, there can be hemodynamic instability due to cardiovascular system that can get affected. They can have arrhythmias due to the impact of the TBI and its influence on the cardiovascular system, and they can have myocardial dysfunction, so on and so forth. So this understanding needs to be there. So whenever there is a traumatic brain injury, so what do we understand? So we understand. So in normal brain, what we understand is there is normal blood-brain barrier and there is normal neuronal function. So all this gets disrupted when there is a traumatic brain injury, which you can broadly categorize into primary and secondary. Primary is what the nature of the impact or the insult that has caused injury. So in primary brain injury, there are sort of 4 components that tend to occur. There is a necrosis, there is microhemorrhages that tend to happen, there is edema and inflammatory. So these are the 4 key components that happens due to impact. So there is necrosis, microhemorrhage, edema, and inflammatory changes, which tends to impair or damage the blood-brain barrier and ischemia. So secondary brain insult, again, there can be blood-brain damage, and secondary insult can be avoided by maintaining the 7 normals which we spoke about. Along with this, the edema causes hypoxemia, And this hypoxemia leads to tissue ischemia, and this leads to some influx of basically there is a mitochondrial dysfunction due to the influx of iron and calcium into the mitochondrium, and this mitochondrial injury. And this hypoxemia that sets in due to edema and hypoxemia releases a lot of these deleterious sort of an elements, which is caspane, caipins, reactive oxygen species, and so on and so forth, which causes apoptosis or cell death. So this is the sort of pathophysiological conundrum that tends to happen in traumatic brain injury. Along with this, we need to understand there is sympathetic overactivity that tends to happen when there is a traumatic brain injury, which can affect multiple organs which are innervated by the sympathetic nervous system. And there is a descending inhibition on the spinal cord that also can get impaired due to the traumatic. So as you see, it is a syndrome. When there is a traumatic brain injury, basically it can have deleterious effects on your whole human body. Cardiovascular system is one, sympathetic nervous system, which can have sort of an effect on multiple organ systems, and it can have effect on the spinal cord because the descending inhibition is sort of lost. So these are sort of pathophysiological conundrum that tends to happen in severe TBI. And because of the sympathetic overactivity or sympathomimetic response, they manifest with various sort of a symptomology. So they can manifest with tachycardia, they can have high temperature. So that's why we always throw in antibiotics when there's TBI. So this temperature response that you see is due to sympathetic activity. So please don't indiscriminately use antibiotics in TBI because they could have some sort of a temperature. Obviously, exercise your clinical acumen. They can have hypertension, tachypnea, and decortication. And because there is sympathomimetic as a result, there is sort of a release of cytokines, catecholamine surge, which leads to hypoxemia and secondary injury. And oxygen demand and supply sort of a ratio gets disturbed, and there is a gross sort of an imbalance, which again leads to edema, tissue hypoxemia, release of caspases, reactive oxygen species, and apoptosis. So that is the sort of a conundrum that tends to again happen due to sympathomimetic hyperactivity or sympathomimetic response. So, and as I said, the type of catecholamines that have been referenced is all this typical tumor necrosis factor alpha, interleukin 1 beta, interleukin, and this leads to alpha and beta activation. And this activation of this alpha and beta leads to sort of endothelial cell injury and the leakage of the endothelium, and they create some sort of a prothrombotic state, and there can be some sort of a microthrombi. Alpha activation leads to vasoconstriction, increases in the pulmonary capillary pressure, which can lead to sort of pulmonary edema in a traumatic brain injury. And the beta activation tends to cause cytokine storm, causes myocardial necrosis or dysfunction, which leads to myocardial LV dysfunction and cardiorespiratory dysfunction. So this is the sort of vicious sort of a conundrum that happens. So TBI is not a simple thing. As you see, the primary injury has a separate set of problems that will create. Secondary injury has a separate set of insults that it can cause. Then you have this whole sympathomimetic response that gets activated. And there is a huge catecholamine surge, which is the activation of alpha and beta receptors, which again have a huge sort of an impact on various sort of organ systems. And of course, along with all this, there is this brain and heart crosstalk that tends to happen based on the structural elements that are affected that leads to deleterious effects on the cardiovascular system. So this is the sort of a whole sort of a tsunami that tends to happen when there is a TBI. That's why the outcomes are influenced by so many variables in TBI. So there is an entity called trauma-induced coagulopathy, where of course, like any other, it's called TIC, trauma-induced coagulopathy, where typically they can have high INR, APTT, and low platelets. And it has shown if someone has a trauma-induced coagulopathy, it leads to sequential worsening of the secondary brain insult that we all spoke about, and it can disrupt blood-brain barrier. It leads to brain edema, tissue hypoxemia, and apoptosis and cell death. So trauma-induced, if there is a coagulopathy in traumatic brain injury, please bear in mind that it leads to worsening of the secondary brain injury, and it cannot be ignored. And for all the trainees, remember, we used to call as lethal triad. Now they have come out with a lethal diamond. So what was lethal triad? Coagulopathy, hypothermia, and acidosis is something we need to avoid. Now they have added hypocalcemia as another component. So in exams, if they ask lethal diamond, it is in addition to all these three, you have hypocalcemia and hemoglobin to be maintained. Now the more evolving evidence suggests we need to maintain hemoglobin little on a higher end. Maybe 9 is much better than 7 is what has been shown in the recent trials. platelets to be maintained more than 1 lakh. And crash trial has shown benefit of tranexamic acid in reducing the hematoma expansion in the traumatic brain injury. That is something that you could keep in back of mind. So in traumatic brain injury in acute phase, what are the interventions we do? So in acute phase, it is a time-bound intervention. So if there is a need for evacuation of hematoma, surgical intervention, osmotherapy, and organ support has to be put in place. So early detection of the type of interventions that you need to put in place has to be considered in this primary injury or acute phase. In secondary injury, the whole focus is on optimizing the renal function, optimizing the respiratory, and optimizing the cardiovascular function by absolutely ensuring that normotension is maintained, avoiding hypotension. Hypotension is really bad. All efforts should be put in place to avoid hypotension. Of course, if blood pressure is very high, you need to control it. And fluid balance. Studies have shown the cumulative positive fluid balance, even in traumatic injury, has shown to worsen the brain edema by sequestration of all these fluids in the brain. So net neutral balance, and in the later stage, try to maintain a little bit of a negative balance is what is favorable. And of course, you can use gadgets like echo and advanced hemodynamic monitoring to make sure that you are maintaining euvolemic state and sort of safeguarding the function of important organs like kidney, lung, and the cardiovascular system. And the focus has been on avoiding blood pressure instability. So, Brain Trauma Foundation very strongly recommends that aggressive reversal of hypotension. So, you cannot allow traumatic brain injury to have any hypotensive episodes. If there is any, it has to be addressed with immediate sort of a reversal of this hypotension. And systolic blood pressure should be maintained more than 100 to 110. Most importantly, the intent is to maintain cerebral perfusion pressure, which is a difference of mean arterial pressure minus ICP, and it needs to be maintained between 50 and 70 or 60 and 70, and it is level 2B recommendation. It is shown to improve the survival, and it is shown to lead to favorable outcome. And the BTF and the suggestion is to early initiation of vasopressor, not wait for only fluid resuscitation to correct the blood pressure. Early initiation of vasopressors like in sepsis to absolutely avoid hypotension in traumatic brain injury is sort of overemphasized. And now this question, when to use hemodynamic monitoring, there is a strong emphasis on using like in sepsis. If you look into the sepsis guidelines, the recommendation is you need to have invasive monitoring of blood pressure. Arterial line is mandatory for someone with hypotension. Even in traumatic brain injury, use of arterial line or invasive blood pressure monitoring is a standard of care, because of late it is becoming irritating that some of the specialists come and say that you are putting art lines in ICU. Yes, we are going to put, and it's a malpractice if you don't put arterial line and don't monitor. People come to ICU for a good monitoring of blood pressure. And if you want to monitor these patients in the ward by not putting invasive, jolly well manage in the ward. But if it's come to ICU, this is a protocol. All guidelines, surviving sepsis, all guidelines suggest good invasive blood pressure to have absolute control over blood pressure. Avoiding hypo and hypertensive is the norm. So please, my friends, the trainees, tell all the super specialists, if they question you, you need to put invasive sort of a blood pressure monitoring in any unstable patients. And if they want to maintain without that, let them jolly well manage in the ward. It's a malpractice if you try to manage these patients without invasive blood pressure. And the intent is to avoid hypotension, avoid hypoxemia, avoid. And this is really getting irritating for us when someone comes and tells, why are you putting Artline for my patient? So please tell them, you need to learn your lessons. You cannot do this. It's a malpractice if you try to manage such patients without invasive blood pressure. Please tell them, my good friends in intensive care. And what about autoregulation? So autoregulation is something that needs to be focused on. So what basically this picture denotes to you is the cerebral blood flow is sort of maintained with a cerebral perfusion pressure between 50 to 150. So below 50, you have lost the autoregulation, and more than 150, your cerebral blood flow gets affected. So that's what. So there is this sort of a auto adjustments of maintaining adequacy of cerebral blood flow at a prerequisite perfusion pressure between 50 to 150. Of course, we don't maintain up to 150, but the suggested range is 50 to 70 is considered safe. Why we consider safe? Because your blood flow to the brain gets impaired at the extremes. Less than 50, it gets impaired. More than maybe 120, 130, your cerebral blood flow gets impaired. And this is what we call it as autoregulation. The body has its own innate mechanism to control the blood flow in this thing. So this is now what has been shown to denote your good sort of an auto-regulation. Obviously, you need to determine who is auto-regulating well, who is not. For that, the index that we have determined is pressure reactivity index. So pressure, as you see, very simple. Pressure reactivity index is your cerebral perfusion pressure between 60 to 70. If your reactivity index is minus, so 0 to minus 0.6, where you have a good auto-regulation. Once it becomes positive, so if it is less than 0, it means you have intact autoregulation. Once it becomes positive and it goes more than zero point 0.3, then it means they have impaired autoregulation and your whole sort of a cerebral blood flow dynamics get impaired. So this index is a good sort of a modality to determine if the patient is autoregulating well and maintaining good cerebral blood flow is what we need to understand. So just remember, it has to be negative. Once it goes to positive and more than 0.3, it means they have lost an autoregulation. And which fluid is best in TBI? So there's no doubt on this. Crystalloids is the fluid of choice in traumatic brain injury and strongly suggested to avoid hypotonic and glucose-containing fluids because this can worsen the brain edema and this can increase the intracranial pressure, and avoid albumin because the safe study has shown it worsens the outcomes when albumin is used in traumatic brain injury, and avoid balanced solutions because balanced solution has shown to worsen outcome, and this has come from the basic study. So this is something you can keep in back of mind. Crystalloids are good enough and they are considered the fluids of choice in traumatic brain injury. And as I said, avoid cumulatively positive fluid balance because the center TBI study has shown that positive fluids sort of a balance increases the fluid sequestration in the brain, worsens the brain edema, and worsens neurological. So even in traumatic brain injury, avoid cumulative positive fluid balance. So summing up, so what is the take-home message, which I'm sure most of you are aware and intuitive, is understand the concept of brain-heart crosstalk and understand the concept of traumatic induced coagulopathy, which is called TIC, and which has a bearing on worsening of secondary brain injury. And BTF suggests aggressive reversal of hypotension and early usage of vasopressors. Don't wait only for fluids. And the whole literature suggests use invasive monitoring in traumatic brain injury where you need to have an absolute control. If someone is telling you don't use, because of late I've been seeing some of the specialists coming that ICU are putting heart line simply. Please sell, it's a malpractice. They cannot tell you this. So this is very important, friends, and they can manage it in the ward if they wish to. And measure CPP. And for that measuring CPP, you need to have control over the blood pressure readings in a real time, and CPP monitoring with a pressure reactivity index is something that is very important. And fluid balance. Don't allow patients to have hugely cumulative fluid balance. And crystalloids is the fluid of choice. So this is what came out on this nice sort of a review article. Pretty much what we all knew. So a little more emphasis on monitoring ICP and CPP and the cerebral reactivity index. And early use of vasopressors has been emphasized, and invasive hemodynamic monitoring in all these patients to have absolute control over the blood pressure and to avoid hypoxemia, to avoid hypotension, and to avoid anemia, so on and so forth, has been emphasized. And don't maintain cumulative fluid balance and try to keep them net neutral balance is the take-home message in this whole article. So thank you, friends. Request you all to submit your valuable work to Journal of Acute Care. And of course, you can visit my website to rehear to this lecture. So thank you, thank you, thank you, one and all.